Welcome everyone to this webinar on consumer engagement in research and healthcare. It's just after 1 o'clock, so I think we can probably get started. So just wanted to welcome you to the webinar that's brought to you by the Perinatal and Paediatric Epidemiology Special Interest Group of the Australasian Epidemiological Association. I'd like to begin by acknowledging the Gamaragal people, the traditional custodians of the land on which I am today, and also acknowledge the traditional custodians of country right across Australia and recognise their continuing and deep connection to the land, waters and seas, and pay my respects to ancestors and elders past and present. And also, as we're an Australasian organisation, I would also like to pay my respects and acknowledge Ngāiwi Māori as the tangata whenua of Aotearoa, and extend my respect to all Indigenous and First Nations people who are joining us today. And also welcome those who are joining us from across Oceania and further away as well. So really looking forward to the session today. We have some wonderful speakers. Associate Professor Angela Todd will be chairing the session, and we'll have presentations from Dr. Natasha Donnelly and Associate Professor Ray Thomas. And I'd like to thank them for their time today. The format for today will be presentations followed by a moderated discussion. So please write any questions in the chat, or if you'd like to turn your camera on and ask your question directly in the discussion part of the webinar, then please put up your hand using the put up your hand function in Zoom so that we can call on you. And I'd also just like to note that the session is being recorded as well. So I'll now introduce, I'll hand over to Angela, who will chair the session. Thanks, Ange.
Thanks, Deb. I'm just going to share my screen, hopefully. Okay, is that clear enough, Deb? Great, thank you. Hello, everyone. I too am on Gamaragal land, and I would also like to acknowledge and pay my respects to elders past, present and emerging. So my role is to give you a little bit of background context to the issue of involving consumers in health, in research and healthcare, just to provide a bit of context before our speakers begin. So some of you have probably heard the saying, nothing about us without us. And this really has a long history. And I've got to say, I was quite surprised when I did a little bit of research about this term, that it comes from way back in the early 1500s or its equivalent. And it was actually a political motto used in Poland back then. And it was then subsequently used by some other European countries, and didn't really emerge in its English form that we know today until the 1990s, but first through disability activists. But it has been widely adopted by many human rights and advocacy groups, including health-related groups, with a strong message that if we want to work and develop policies, programs, funding decisions about various population groups, that we really should involve representatives of those groups. Just one thing before we go further, this is just an issue of language, but in Australia and a small number of other areas, we refer to this sort of space as consumer and community involvement, or CCI. But in many other countries, including the US, the UK and Europe, they actually refer to patient and public involvement, or PPI. So for those of you doing systematic reviews in the future, make sure you use multiple terms. So the issue of involving consumers in healthcare started in Australia a long time ago. And you can see from these various screenshots that I've displayed on this slide, there are a lot of resources, both for consumers and for healthcare workers, about how to involve and work with consumers in healthcare. There resources, templates, training advice. Most of these come from some of the consumer advocacy bodies that are represented throughout the states and territories of Australia. But you see that there's an awful lot available to support training and the operations and engagement of people in healthcare decision-making, healthcare design. One of the things that's shifted, though, is an increased focus of involving consumers in health research. Now, in the area of health research, language becomes quite important. And again, just by way of some background, some of the terms that you might hear: participation, engagement, involvement, co-design, co-production. It's important to know these words have got particular meanings when it comes to consumer involvement in health research. And they're not all synonymous. Perhaps engagement and involvement are the closest that might be, but the others have got quite distinct meanings. So, for example, participation of consumers in research is specifically referring to patients and consumers as participants or subjects of research. So if you're using that word, it has a very specific meaning now in this context. Alternatively, consumer engagement has a range of meanings that are much more, that are broader and much more encompassing, of involving researchers, consumers and researchers together in all steps of the research process, both in the design of the questions that we're asking, the methods that we're using, how we interpret the results, and of course, how we translate those results. Interestingly, in Australia, the research community has opted for the term involvement. It's less common to see the word engagement in official documents. Again, that's just the practice that's happened in Australia. So, for example, the NHMRC has a statement. Its statement is about consumer and community involvement. It also has a website that's got a range of resources that are intended to help people in how to best do consumer and community involvement. They aren't the only people providing resources in this area. The Australian Health Research Alliance, which is a sort of a loose network of translation centres across Australia, has a special focus on consumer and community involvement. It's one of its national collaborative initiatives, and there are a range of tools and resources and reports available on the website there around consumer and community involvement. There's a position statement jointly authored by ARA and the Consumer Health Forum of Australia. There's a nice short narrative review if you're looking for a little bit of background information. The other two reports on this slide are not quite yet available on the website, but should be in the next couple of weeks. Under the Australian Health Research Alliance, you may be aware there is a specific women's health research translation and impact network. It has 9 priority areas of health and health research that it focuses on. And it's also got a special focus on consumer and community involvement, and that might be of interest to this audience. There's also a toolkit that's an online resource developed by the Australian Clinical Trial Alliance that focuses on people involved in clinical trials who want to engage consumers in clinical trials research. So, you know, we're not starting with nothing. Even though many of us don't have a lot of experience in this space, there are a significant number of tools and resources to help us get started. But what's important is our speakers today who do have experience in this space, and that's the reason why we're here, is to actually learn from people who have been working either as consumers and researchers collaboratively on research projects. And so it is absolutely my pleasure to introduce our first speaker, Dr. Natasha Donnelly. She will let you know she's is both a consumer and a researcher, so she will bring a really interesting perspective of those dual roles. So I'm very pleased to hand over to Natasha now. Natasha, I'm just going to stop sharing.
Thanks, Angela. Hopefully you can see my screen now.
Yep.
All right. Now just find my. Okay. Thank you to Deb and Ivy for the invitation to speak at today's seminar or webinar, and for the introduction, Angela. I would first also like to acknowledge the traditional owners and custodians of the lands and waters on which we're all meeting today. In my case, that's the Warramai people in Port Stephens, and pay my respects to their elders past, present and emerging, and to any First Nations people present today here, and I gather in New Zealand as well. Sovereignty has never been ceded. It always was and always will be Aboriginal land. As the title of my presentation suggests, I have a fairly unique perspective on this topic, having a view from both sides. As a consumer representative in maternal and perinatal health for almost 20 years now, and as a researcher in perinatal epidemiology for the past 10 years. Today, I just want to share a little bit about my experience, as well as share some tips, I guess, and resources for engaging with consumers in research. I guess the first thing is to explain who I am and why my experience is relevant to the members of the SIG. I first became involved as a consumer rep after the stillbirth of my second child, my daughter Soraya, in 2002. And I was really projected into the work as a consumer to make change for other people. And that's a pretty common way that people get involved as consumer reps. Many get involved after they've had a bad experience, which is what happened to us. And while I couldn't change what had happened to me, I could try and make change for other women and families. And there are some people who get involved because they've had a great experience, and certainly in our area of maternity care, you get very passionate women who've had a great home birth, for instance, and women who've had a terrible experience. So there are various motivations as to why people get involved, and this is how I got involved. And I certainly consumed more than my fair share of maternity services over the years, having had, I think, I kind of lost count, 9 pregnancies maybe over a 10-year period, which included 4 births, 3 miscarriages, a loss of a twin. I've had private care, public care, certainly experienced a lot of maternity care. I had my third child, Rowan, was a 31-week emergency Caesar after 10 weeks in Royal North Shore Hospital antenatally. So I've also had experience in neonatal intensive care and a premature baby. As I said, miscarriages as well as a full-term stillbirth. And I now have 3 beautiful surviving children who, have had to share their mother with research and consumer activities for a long time now. And I think Angela touched on the fact that consumer involvement used to be very much focused on the healthcare aspect, and certainly my work initially was very focused on maternity care and the healthcare system, but then it's certainly morphed over the years to have a far more of a research focus. And I think consumer involvement in research is certainly maturing now, and there's a lot more of a focus than there used to be. So then I went back to university again in 2009 and redid my Bachelor of Science in Health Information Management in order to do research. So I wanted to convert, I guess, or professionalise my involvement as a consumer and take it to that next step and be able to contribute to research in the area. And I was really, really lucky that before I graduated, I got my dream job at the National Perinatal Epidemiology and Statistics Unit, the NPSU, at the University of New South Wales, and I've been there ever since. So for the last 10 years, I've been working there. And my research has focused very heavily on models of maternity care, and that's where I ended up doing my PhD as well. But I've also worked on maternal mortality and stillbirth epidemiology projects. I now manage projects in all different areas of perinatal epi, including in IVF. And now more recently, I'm kind of splitting my role between the work in perinatal epi and moving onto medicines intelligence as a program and communications manager for the new Medicines Intelligence Centre of Research Excellence. So I really managed to turn my consumer representation experience into my profession now and be able to do research. So I guess to get to see things from both sides now, which is lucky, I guess, but it's also difficult because I'm trying to move out of the consumer space and I do tend to get pulled back in. So what work have I done that makes me, I guess, an expert or a professional consumer and be able to speak to this today? And this screen just has, I guess, a selection of logos of the organisations I've worked with, both in the past and I currently work with still in some capacity as a consumer and also sometimes as a researcher. And sometimes that role is very blurred between being a consumer representative and a researcher. Sometimes I sit in both roles in a chair, and you know, when you talk about committees and things like that, often it's very pragmatic to have people represent, say, their profession as well as their college, for instance, and I tend to do both roles in a lot of organisations. To be honest, I also get exploited for that as well, because there are some organisations that get me on as a consumer knowing that they're getting a researcher for free. And, you know, I probably use that role as well, both ways to get onto things that I wouldn't normally as a researcher, but I can as a consumer. And these organisations, such as the Australian College of Midwives, I've worked with since my daughter was stillborn, and New South Wales Health as well. And that includes, I've been on boards, I have contributed to guideline development, reviewed perinatal and maternal deaths. I still do continuing work with the Stillbirth Centre of Research Excellence in their Safer Baby Bundle, in both the development and implementation of that. The Perinatal Society of Australia and New Zealand, I was I founded their consumer advisory panel, and I'll be talking a little bit about the toolkit that we developed and is available freely online. And that is a toolkit for engaging consumers in research, in perinatal research. And similarly, the work that I've done with Maridula Budjari-Gumal, or SPHERE, is also, you know, commenced as a consumer and then has also moved into research. But I guess one of the areas I'm most proud of in terms of research capacity is the International Vasoprevir Foundation, which I'm the Vice President and on their board. And it's a consumer organisation, but we've actively involved ourselves in co-design and co-production of research. And that initially we did a project before I joined the NPSU. Some of you may be aware of AMOS, the Australasian Maternity Outcome Surveillance System, which is looking at rare obstetric conditions. And we co-funded and co-designed a project with AMOS to a surveillance study on vasoprevir in Australia, which was one of the largest prospective study undertaken in the world on vasoprevir. And I continue to work with them as well as the Australian Preterm Birth Prevention Alliance, both as a researcher and as a consumer. So I kind of have a lot of experience. Why involve consumers? Sometimes it isn't easy to understand how consumers can be relevant to your research, particularly in epidemiology, where we're dealing with data and not people. I remember I had a very senior bureaucrat from an organisation I won't name, who once asked me, when I suggested we needed a consumer on a committee that involved a maternal mortality project. And this particular bureaucrat asked me, why on earth would we want to have a consumer, and how could we have a dead woman participate? And at the time I was absolutely horrified, but it spoke to this idea that people really don't understand the purpose of a consumer representative in this sort of work. And I've had clinicians and researchers alike say that they don't need a consumer on their perinatal related project because they've had a baby, or someone else on the committee or in the project's had a baby, and surely they can just be the consumer. But there is a difference between someone who has been a health service user or a consumer of healthcare and a consumer representative. They are quite different. As Angela has referred to in her presentation, there is that great slogan of nothing about us without us. And you should be involving consumers. And by this, I mean consumer representatives, to give an informed understanding of their lived experience that is relevant to your work. The research, you really want to ensure that those who are directly affected by the research have a say in that research. And I think Ray's going to talk a lot more about that in her work with community juries. about involving members of the public who might be affected by a particular area. And it doesn't matter whether it's clinical research or epidemiological research, the same principles must apply. And involving consumers makes your research more relevant. It makes it more appropriate and less about doing it just for the sake of it, but making it appropriate to, I guess, the end user, if you like, and those who impact on it most. And it certainly has a greater impact, and particularly in terms of translation, if you do involve consumers from the outset, as well as at the endpoint of dissemination. So lots of really good reasons to involve them, but particularly about making it relevant and appropriate and meaningful. On this slide, I have what I call the continuum of consumer involvement in research, and it moves from the passive, of really no involvement or that sort of informed or one-way approach, right through to consumer control or consumer-led research. And there are some instances that you would involve consumers on one end of that continuum rather than the other, or somewhere in the middle, but the idea is to move forward in order to have more meaningful and less tokenistic involvement of consumers. And I think Angela touched on that a little bit with the different uses of language, that there is a difference. Participation is really as a subject, which is where that none, I guess, sits. You can have the touch, I guess, of consumers by showing the materials, having them sit on a committee, but it can really become far more meaningful when you look at co-production and co-design. And on this slide, these are just some of the areas and ways that you can involve and engage with consumers, or both at an individual research or a project level, as well as an organisational level. So starting at the very beginning, it's looking at research priority setting, and that's something I've done closely with the stillbirth CRE, for example, and that's identifying with other consumers what is important in terms of research in an area. And the James Lind Alliance is fantastic. I think they're in the UK at doing that. Similarly, program and project planning for your whole unit or organisation. By involving consumers early, it's about finding out what's important to them, because there's no point us investing very scarce resources in research funding on areas that really aren't going to be applicable or of relevance to consumers and the end user. Funding decisions, if you happen to be an organisation that funds, whether it's scholarships, small grants, things like that, then involve consumers in reviewing those funding applications. And the reverse of that is to, as a researcher, involve consumers in developing your grant applications. Don't call them the night before the grant needs to be submitted and say, I really need to put your name on this to meet the NH and MRC requirements. Get them involved from the very beginning, and it becomes a lot more meaningful. One of the most traditional areas of involvement, I guess, is preparing material for consumers that you're going to use in your research, whether it's patient information and consent forms, surveys, those kind of things. Consumers are very involved in making sure that the language and usage is appropriate. In the same way, feedback on data collection methods and recruitment. Engage with consumers working in that area and consumer representatives, and you'll find out a whole lot of interesting information about appropriate ways to approach people, areas to find participants, when to organise things. Data analysis and interpretation. Don't underestimate the impact and input of consumers in that, particularly in, I think we tend to, we're getting better, I think, in involving clinicians and clinical academics in this area to look at the relevance and interpretation of the results that we get, but really consumers are really important in that space as well, and don't underestimate their ability to interpret that information and look for things that you may not see. Dissemination and reflection on a project. So to be able to apply your results and actually disseminate and translate that into practice is really important to engage with consumers, whether it's for them to disseminate in lay media, or whether it's to help them, to help you with the language. But we need to move outside of the traditional, academic journals when we want to really disseminate and have good translation of our results. And ultimately, research co-design and co-production is where we'd like to be, and that is having consumers as equals in investigators and in our research teams. And I think they do a really good job of that in the UK, and actually quarantine funds as well as positions and training to do that. Here are a few tips to remember. I'll just go through these. A lot of these will make sense, but they're really important to consumers. And that start them early in the process. As I said, not the night before the grant's due. Start right at the beginning in identifying your priorities. Please include dollars in your budgets. And I know that's really hard to do because you've got a lot to fill in other items to fill in, but it's often an afterthought. And it's really important to pay consumers for all of their contribution. Often they're not paid at all, but it can be as, it does mean little things like paying for parking, paying for childcare, paying for their time, because we do give up a lot of time, consumers do, and it's not acknowledged. And it may only be a small amount, but it actually speaks to the value of their contribution. Invest in training, both for researchers as well as consumer representatives, because don't just expect that a consumer is going to be able to contribute in the same way without training. And there are a lot of resources, and I'll share some, and Angela mentioned before, it's all out there, you just need to locate it. I'm terribly guilty of using jargon in my work and in the maternity space. We all do, but it's really important when working with consumers to avoid it. Because it's very disempowering. There's already a power imbalance when you involve consumers and clinicians and the health system, but it's amazing the power that lies behind language. And so you really need to be cognizant of it, and also provide them with, even if it's a cheat sheet of common acronyms and jargon, it really does help them to engage and participate. Don't put them in on their own. Don't isolate a consumer by putting them up on their own. They should always consider having two or more, because they do need to support each other, and it also helps to have that breadth of experience. As I mentioned, I've become what you call a professional consumer, and you can't unlearn things. So the longer a consumer is involved in this space, the more they pick up on the language. And now, like, I think as a researcher, it can be hard for me to think as a consumer, particularly over those tasks like reading material to make sure it's understandable by consumers. But if you have a breadth of experience, you can then have what I call a naive consumer. So someone who is really fresh, because they're going to see the things with a completely different eyes to someone like myself. And also remember that they don't represent everybody. So I can represent my experience, my lived experience, as well as the experience of my networks, but I can't speak for Aboriginal and Torres Strait Islander women. I can't speak for migrant and refugee women. I'm disabled. We have, it's really important to consider the breadth, and it can be really hard. You can't get a representative from every one of those different parts of the community, but it is always good to remember that they're not representing everybody. Hurdles. I'm trying not to stick to the negatives because there are a lot of barriers. And so it's really important that you're aware of them. And I know I'm speaking for a long time, so I'll flick through these really quickly. Where do you find them? That can be really hard. I get asked all the time, and I know Angela does too. I'll get a call saying, oh, do you know a consumer that can work in cardiovascular health? Do you know a consumer? And, it can be hard to find, but Google's a wonderful thing. And the first step is to look for an organisation, a consumer-based organisation, support group, anything like that is specific to if it's a condition you're working in. Otherwise, there are a myriad of consumer organisations you can go to ask for representation. And if you do have a clinician, particularly as part of your team, it's really good for them to cultivate, patients that they have worked, and it's a terrible word to cultivate, but to build those relationships with ex-patients or people that have been involved and they think might want to make change, and get them trained. And once you've got really active consumers, it's really important to hold on to them. Consumer availability, it's not just about locating them, but it's about keeping them, and being cognizant also of don't organise. If your project is a maternal or perinatal related project, or paediatric even, don't organise a meeting at 9 o'clock in the morning with a parent representative because they're trying to get kids to school. Don't do it at 3 o'clock when there's a pickup. Don't do it on the 6th floor of an old hospital that they have to walk upstairs when they've got a pram. So some of these things, that they're really simple things, but they make a big difference to the consumers. Training and support, I've already touched on. Consumer beliefs and cultures as well, it's very important to be aware of. Being really clear about expectations. Consumers worry sometimes that they don't have the knowledge, that they can't contribute. They need to be told, and that there is no expectation that they're a researcher that's going to have the same input. That's not their role. And it's also important to clarify your expectations. I've talked about language. There are financial barriers. As I said, it costs me a lot to give up time normally and in the past to participate, but it's something that I find of value. And for a lot of consumers, they do give up their paid work to do it. And so there's also an opportunity cost to that. Temporality is a really important one, particularly in the maternal and perinatal space. And what I mean by that is consumers are really passionate for a very short amount of time because they've just had their baby, or they've just been pregnant, or they've just been involved in the neonatal intensive care unit. They want to get involved, and you know what happens is they're very well meaning, but it's really hard to keep them because life takes over. They either go back to work, they have another baby, they move on to other things. So once you've got them, it can sometimes be really hard to keep them. Resources we've touched on. You don't have to reinvent the wheel. As Angela mentioned, there are so many great resources out there. This is a really small part that I've listed here, and some of these organisations, it's freely available. You just need to find it, and there's no point starting things from scratch again because it's out there, whether it's training, templates, guidelines, as we call it, a toolkit that points to, the PESANS toolkit in particular, points to existing resources. We've just put it together. And we've also got almost a register of different consumer organisations that have anything to do in the maternal and perinatal space. And finally, if you remember just one thing, it is that tokenistic involvement is actually worse than no involvement. Don't do it just for the sake of ticking that box to say you've got a consumer involved. It's insulting to the consumers, and it actually won't make a difference to your research. So please make your consumer involvement count. Thanks.
Thanks very much, Natasha. That was really, really interesting. And I'm so impressed by how one human being can do so many things, wearing multiple hats. Really, really terrific. You must be a gold mine to have involved in projects. Look, one of the things that you mentioned that really resonated with me was the issue that no one consumer can bring the perspectives of, you know, the population that you're trying to work with. And that's a really important thing to remember. And I think it's a bit of a nice segue into the presentation by Ray Thomas. Ray is from Bond University, and she's done some really interesting work around community juries, where you are bringing more than one consumer and community representative together, so you can benefit from multiple perspectives. But that also brings its challenges. So we're really looking forward to hearing Ray's presentation. So Ray, perhaps if you can share screen, and we'll look forward to hearing from you.
Thank you. I'm doing that whole Zoom. Can you see my screen stuff? Right.
Yep.
All right?
Yep, okay. Perfect.
Excellent. Thank you very much. Okay. So look, again, thank you very much for the invitation to talk today. It's really great to be speaking to such an enthusiastic kind of group of people. And I'm going to talk to you today about what I consider to be a different way of including the informed opinions of patients and publics into health guidelines and health policies. And we've been working on this for quite some time. And I work at the Institute for Evidence-Based Healthcare. So I am a full-time researcher, and this is something that I'm particularly passionate about. But in discussing this, we realised that I'm kind of melding quite a few different bits and pieces here. I'm actually working with consumers and community members to identify different methods to move into health guidelines and policy development. So it's a really fun space, and I am grateful to be able to share these ideas with you. And one of the things I think we need to be careful of, and we've spoken about it before, is that many times in health policy and in guidelines, developing health guidelines, patients and publics are asked at the very end of a project. So they're given a lovely draft and said, can you give us feedback on this lovely draft, please? And in that respect, we're actually trying to give them something. They're trying to navigate from an extremely unknown starting point, and it just makes it really difficult. And so that's that right at the end kind of last minute stuff that Natasha was talking about. The other one is when, you have your single support, you have your single person or your buddy support who've been invited to attend a guideline group of experts and give their opinions in that environment. And this can be really challenging, and Natasha talked about this too. They might lack the training, or that there's this power differential in the room, and they might feel intimidated by the experts that are there. And so this has some challenges and problems also. And then, of course, what happens is that you often get the same person over and over and over and over again until they fall down exhausted. And I'm trying to think about a different way of doing these things. And I'd like to talk about an alternative today. And this is where my research on community juries has come to the fore. And since 2014 in the Institute, we've been working on this concept of community juries. And it isn't a new concept at all. It was developed in the USA in the 1970s by a centre called the Jefferson Centre. And over in the USA, it's called citizens' juries. But when my colleagues and I got together in Australia, we actually thought the word citizen wasn't as inclusive as what we wanted it to be. So we've termed it community juries. And they are a method of deliberative democratic processes where we gather together the people most affected by the problem that we want to discuss, and we want these people to provide us recommendations for. So I want to be a little bit clearer about what I mean by that. So when we're looking at things like how to define a health condition, right? So if we're looking at, let's pretend it's hypertension. So the definition of hypertension will be a particular number over another number. That's a definition of whether or not you have hypertension. And those definitions often change regularly. And if we want to think about how do we define a health condition, or even how we test for a health condition in asymptomatic people, then we need to gather the informed opinions and the values and preferences of people most affected by that particular question, right? And so an example of that, in a minute, I'm going to talk about a community jury we did on screening for prostate cancer using the PSA test. And in that particular group of people, as you will see in all of our community juries, we make an effort to recruit people in an elaborate random digit dialing process. We recruit people who are affected by the condition. So I wanted men because they have prostates, right? I wanted men in a particular age group who are eligible to be tested for prostate cancer. But importantly, these men were not able to have had a diagnosis of prostate cancer. Because what happens when you're labelled with a health condition, it changes how you think about that health condition. And you inherently bring to the table different ideas and different opinions, which are seriously important if I'm interested in knowing about the treatment of that condition or the process of being diagnosed with that condition, but not if I'm interested about screening for that condition or how do we call that condition. So we conduct our community juries over a really intense 2-day process, and we're working around some of the issues with that and trialing different flexibility techniques now. But it's very intense, and it involves a lot of expert information. So we're very, very careful about if we ask the community jury to deliberate on a particular question, we actually have to provide them with all the information they need in order to provide a recommendation for that question, right? So we deal with that really early on and provide an awful lot of information. It's really quite exhausting, unfortunately. But what's unique about the process is that the members of the community jury get this ability to Q&A with the experts, and it's in real time, right? And if they have any further questions, we ring them back, we bring them back in, and we talk about it some more. We then have over 2 days, so you have a reflection period overnight where you can go home, talk about it with your family, your friends, whatever that might be, and you come back the next day, thrash it out a bit more, you have a facilitated discussion, and then importantly, an unfacilitated discussion. So us researchers and facilitators, we leave the room and the community jury members get to discuss it amongst themselves and then feed back their recommendations to us. So I've conducted a number of community juries so far, but I'm going to talk about 4 different ones today and 4 different research questions that we've been trying to unpack to figure out how best can we use this technology? What do we understand about this idea, and how best can we use this in the future? So 4 different juries, 4 different learnings from a researcher perspective. So the first one I'm going to talk about is the very first community jury we actually ran, and it was screening for prostate cancer. We wanted the men to answer the question, should government campaigns be provided on prostate-specific antigen screening, right? The verdict, after 2 days of intense information, was a unanimous no from all the men. But for us also, there was a research question about, well, look, in these community juries, how do we know that a community jury would have different ideas and different recommendations potentially than other people? So for this very first community jury, we ran a randomized controlled trial. So we had 2 groups, right? And we asked the men a series of questions. And here you can see a graph that shows you that before the community jury, we asked about their behavioural intentions to personally be screened for prostate cancer using the PSA test. And you can see at the start, both groups are the same. Yep, done, 7 out of 10, thanks very much, I'm happy with that, right? But you can see right after the community jury, we have a statistically significant difference where the men from the community jury went, yeah, not really, no thanks, I'm not that keen anymore. And yet the control group, the men who weren't in the community jury, were pretty much the same, right? And this carried on for 3 months after the community jury. So you can see here that providing this information does indeed change and maintain stability over time about people's differing behavioural intentions for this information. So another community jury we ran was case finding for dementia. And this is really important to us because the Royal Australian College of GPs in their Red Book, their preventative guidelines, have suggested that GPs should conduct case finding for dementia. So that's kind of the grey zone between screening and diagnosis. The GP might get a sense that there might be something going on, and so they do some tests to look for dementia in that instance. And this is controversial. So we wanted to ask people who would have been in an age group for screening for dementia, we wanted to ask them, should the health system encourage GPs to practice case finding for dementia in people older than 50? And again, unanimously, after hearing all the pros and cons about this, the jury decided that they didn't want to do that. But there were 2 research questions we particularly wanted to unpack in community jury space for this particular jury. And the first was we wanted to look at the provision of expert information and whether or not that impacted an individual's behavioural intention to have a case finding for dementia, right? So we tracked these participants after every expert presentation and after an overnight reflection and after deliberations. And this is the graph that you can see on the screen here. And so the top left graph is the average of the group, where you can see that they kind of decreased over time. But interestingly, you can see that the information from the experts kind of most people hit it down. Some people, like participant 10, changed their mind a little bit more frequently than the others. But the other thing we wanted to know from this community jury was that whole idea about informed decision-making, which is the whole premise behind community juries, right? So we took some research that was done in another space about determining informed decision-making processes. And it's where you align constructs like your knowledge and you align constructs like attitude and behavioural intentions. And when those 3 align, then it's assumed that there is an informed decision process happening in that space. So we created a survey and we looked at those 3 constructs, knowledge, attitude, and personal behavioural intentions, to see whether or not a community jury had informed decision-making. And 9 out of the 10 people in our group indeed met that criteria for informed decision-making. 1 person didn't, and the reason they didn't was because they rated their attitude towards case finding for dementia really low. So they were really against case finding for dementia, like bottomed out, they were really low. But then they said, yep, I want to have case finding for dementia. So I can't interpret what went on there, but something certainly did. So that's what we learnt from this community jury. Informed decision-making does occur in a community jury. Then it just got fun, right? So then we worked with Gold Coast Public Health, and we started to work with stakeholder groups. What they wanted to do was they wanted to write a local strategy on the Gold Coast to reduce overweight and obesity. And the three local stakeholders were Gold Coast Health, the Gold Coast City Council, and the Gold Coast PHN. And so what we did was each of those organisations committed to reading and responding to the community jury's recommendations for them. And we asked the community jury this was a tough one, right? What does the community jury consider should be the roles of government, the roles of the Gold Coast Primary Health Network, the Gold Coast Hospital and Health Service, and the City of Gold Coast Council in their approaches to prevent and treat obesity? So for each of those organisations, the community jury actually wrote what they considered the roles of each organisation should be in the local space. So of course, there's way too many to mention here. But what we learned from this community jury was this was feasible. They actually did write a local strategy to address overweight and obesity on the Gold Coast. So it is feasible. But on the downside, we also noticed that we really needed to tidy up our expectations of our organisations that we worked with, because really reading and responding to recommendations is the bare minimum. We actually want a little bit more engagement than that. But that was really great. I enjoy all of them, but that was a really interesting one too. And the final one I want to talk to you about today is our priority setting for gestational diabetes that we conducted not last year, the year before, right? So this one was really challenging, and it is still an ongoing effort on our part to work in this space. So in this case, we're working with clinical groups to embed the values and preferences of the informed community into the guidelines of gestational diabetes mellitus. And in that, I mean the definition of gestational diabetes mellitus, and even potentially what we call gestational diabetes. So just as background, clinicians are mostly worried about physical problems when they're looking at gestational diabetes, both for the mum and for the baby. So they're looking at cesarean sections, increased cesarean sections for the mum. They're looking at big for gestational age babies. They're worried about shoulder dystocia, which is when the infant's shoulder is stuck in the birth canal. And they're worried about diabetes later in life for both mum and the baby. So these are all very physical consequences, and these are what the clinicians actually have used to define the blood glucose cutoff for gestational diabetes. But when we were talking with our consumer representative colleagues, who we do a lot of liaising and research with, they were telling us that the women were coming up with different consequences. So they were talking about more medical appointments, they were talking about their mental health, they were talking about other things. So what we thought was, okay, well, let's conduct a community jury to find out, what do women who have experienced pregnancy think, but not diagnosed with gestational diabetes, think should be the consequences of diagnosing gestational diabetes when we're taking it to a consensus panel? What should the consensus panel think are the most important consequences? And it might be physical and it might not. Really, really fascinating and kind of a well-dur in some respects, but the women had very different priorities when they were informed about all the different ones. They prioritised very differently to the clinicians. So in order of priority from the women, they had negative emotional problems for the mother. They were worried the biggest priority for them was the negative mental health status of the mum after a diagnosis of gestational diabetes. They wanted also the priority to be considered what the burden of managing gestational diabetes. They worried about that. They also worried about over-medicalisation of pregnancies, including that whole idea about caesarean sections. They then considered that minimising the risks to the baby was an important consequence that needs to be thought of. But they also thought a positive consequence was that it was indeed an opportunity to change a lifestyle for the mum. And they also, the last consequence, the sixth one on their priority list, was having a big baby. So you can see that this is very, very different to what the clinicians thought. And that was really interesting to us. The research question we learned from this was that it is truly, truly difficult to change the minds of people who are embedded in that space. And this is what they thought. So when we took the information back to the clinicians, they disagreed that they needed to hear from consumers because they already talked about it with their patients, and their patients already told them what the problem was. But remember, their patients had already been diagnosed, right? They were worried because, well, our women said something that varies different to their patients. So that was a problem for them. And because of this different context and these different ideas, it really did create some cognitive dissonance. And they weren't really able to, at the moment, assimilate that information into a new kind of framework. So what they did was they said, nah, we don't trust the community jury recommendations. And so we're really working in that space now to do more community juries and to do it a little bit differently. So that's our learnings from this one. But interestingly, this idea has been noticed. So I've been contacted by members of the Canadian Task Force for Preventative Healthcare, and I've been asked to help develop an engagement strategy around a revolving community jury design for their public advisors network. So what we've developed is we've recruited around about 20 people from the general population because it's a guidelines about preventative healthcare, right? So general population using stratification techniques to make sure we have rurality and urbanness covered and cultural differences covered. And they will do 2 guidelines a year, and they will revolve in and out of those guidelines. Membership will be examined at the end of the year and potentially expanded or moved on. That's the construct we're working on right now. And the first community jury for this advisory network is happening this month. So I'm really looking forward to hearing how that went. The other thing we're doing is we're working with some researchers from Cambridge who have also now conducted 3 community juries, because the Cancer Research Centre in the UK really wanted to consider a new model of screening for cancer where they looked at risk stratification. But what the Cancer Council didn't know was what are the variables that an informed public consider to be the appropriate ones to consider for risk stratification. So we've conducted 3 community juries now looking at risk stratification, and we have a fairly good idea now about the risk stratification variables that are acceptable to general members of the public. And we're feeding that back to the cancer research in the UK now. And finally, just locally, New South Wales, the Agency for Clinical Innovation is looking at community juries to inform a couple of the guidelines that they're currently working on. So it's been noticed, and it's interesting space to work in. And maybe, hopefully, we can change how guideline developers and health policy advisors include patients and public in guidelines and policies. And we can perhaps move beyond the poor same person who does it time and time and time again until they're exhausted, or the last minute attempt to receive feedback, or the lone person in a room full of experts. And I think that'd be a great thing to do. So thank you.
Thanks so much, Ray. What a wonderful presentation and great lessons learned. Really, really terrific. We've been very fortunate to have 2 great presentations from very experienced women. Thank you. Okay, so I'm very happy to open the floor to any questions that anyone here has. Maybe if you can just use the hand raising function, that would help us make sure we don't miss anyone. But I also maybe will start with a question that was posted in the chat by David. Many NHMRC, MRFF and other grants, they often release their applications with short notice and there's not a lot of time for the submission date. So how do you organise an effective community involvement when you've got not a lot of time? And how do you pay for the contributions from consumers when you don't yet have the funding? Would either Natasha or Ray want to take that on?
From an individual, I guess, perspective, which would be very different to trying to organise a community jury in that time, we need to turn around how our organisations do this work, and by that I mean our institutions. They need to be setting an organisational budget, and that's not easy to do. There's got to be some sequestered funds within your research unit that helps pay for consumer involvement, because clearly, you know, if you're applying for a grant, you don't have the funding yet, but unless there is operational funds for that sort of thing, it's not going to change. And that means not just as individual researchers valuing consumer engagement, organisation-wide, we need to do this, and it's people aren't walking the talk.
I think that's an excellent idea about that the money that you save for that. I think that's brilliant. But the other thing I was going to say to David is that rarely is it that we see a grant and go, ooh, I've got a good idea that I've just got off the top of my head. We've actually been working on these ideas for quite some time. And so you probably have a lot of things in the pipeline already. And so hopefully what would have happened is that you've actually created collaborations with consumers, community members for a long time coming, because I don't actually think I work with anybody who's just snaffled up a good idea because MRFF came up with something that wasn't in our area. So it's oftentimes that we're working on something collaboratively for many years, hopefully, in order to put in a grant application. So I think it's a longer process than a couple of weeks, but I acknowledge that, you know, these grant submissions are tight and awful.
Yeah, MRFF is particularly awful, I must say. Thank you. Those are both good suggestions. I think to Ray's point, you know, when we think about pulling together a research team for a proposal, you do tend to draw on people that you already have relationships with, that you've worked with on projects in the past. And so there's a little bit of sort of collateral in the kiddie bank, so that you can contact those people within 2 weeks and say, really sorry, there's a tight time frame, can you help me out here? And researchers kind of know that world. So if you're developing longer term relationships with consumers, they'll start to understand that that's part of the world in which we work too. And I think you'll find that especially you're not asking consumers usually to review the 53 pages of your proposal application. What you're really looking for is some often quite targeted input and feedback on specific sections. And I think you can actually do things in such a way that you can get really helpful and timely advice from people if you set it up well, I think. I don't see any other hands up, so if you don't mind, I'll ask a question. So based on your two experiences, could you perhaps say what's the one or two things you would not do again that you've done in the past in trying to involve consumers? What was, you know, one of the biggest mistakes you made that you try not to do? Yeah, right.
I did exactly what Natasha said not to do. So done that. So in my gestational diabetes community jury, I obviously wanted people who'd been pregnant, and that ended up being mothers mostly. And so what I did was I often have my community juries on weekends to try and make sure that people who work can be included and things like that. But what I didn't take into consideration, and that's dumb because mother myself, didn't take into consideration all of the extra variables that would have come into play for the mothers on a weekend. And so that was a significant learning for me. And so when we run community juries for gestational diabetes, again, I will not be running it on a weekend. We'll be much more flexible in our process. In fact, we probably have a series of them rather than 2 days in total.
Thank you. Thanks for sharing and being honest. Sarah, I can see your hand up.
Hi, I'm Sarah. So I'm based in Dunedin in New Zealand, and I'm involved in medication safety research for pregnant women. And so we are looking at trying to get some engagement from our research base, but we've never done it before. So I just sort of thought, how do we even begin finding appropriate consumer representatives to sort of come along our research journey with us? Do we just advertise? I'm pretty sure there aren't any consumer groups with the hospital already, so any suggestions would be appreciated.
I'm pretty sure New Zealand has, as Australia does, in Australia we have things like the Consumer Health Forum for Health Consumers New South Wales. I'm pretty sure New Zealand does as well. Okay. And so there is an overarching already, consumer organisation. sometimes the problem with that can be that you get not necessarily as an appropriate type of consumer, and I hate to sound sexist, but we'll get the stale white male who gets put on everything that, and it's not applicable to maternity. So, you know, hospitals, because of Standard 2 in Australia, have consumer advisory committees that they try and apply to all areas of health and not necessarily relevant. And but there are maternity support sort of, or consumer organisations as well, if it's maternity specific that you're after, that you can go to. But all else fails, yes, you can actually advertise.
And if you've got clinicians who are collaborators in your research project, you know, clinicians have got lots of patients. You might find they can identify people who might be interested and appropriate. Christine, I can see your hand up too.
Thanks. Hi, everyone. Tash, quick question for you. I love that image that you showed of the, you know, the different levels of consumer engagement working their way up to co-design. And I think that works really well from a researcher point of view. But if you're showing that sort of information to a consumer, is there a feeling of perhaps if they're not up that top end, they're not contributing enough? Like, you know, is there another way of presenting that I guess takes it from a different lens, the consumer lens?
Yeah, I think it's more rather than as an individual consumer, I see that more as how you would engage, say, with a consumer organisation or consumers, rather than directly an individual consumer, if that makes sense. So in terms of that expectation that they should be able to be a co-investigator and design a research project, I wouldn't ever put that pressure onto a single consumer. But you go to an organisation like we did with the International Vasoprevia Foundation and say, actually, we want to do this with you. What's important for you? And involve them every step of the way. And you know, the CRE has done that with the Stillbirth Foundation and Still Aware and various consumer organisations by involving them up front. But I wouldn't apply that lens to an individual, if that makes sense. Unless they
wanted to explain to an individual the scope of where this could lead. Yes. You know, I guess a way of showing that without minimising whatever involvement they're able to do.
Well, it's almost a maturity thing in terms of their training and experience as well, that you say, you know, you wouldn't throw someone in the deep end until you taught them how to dog paddle. So it can be that stepwise and succession planning almost, and I don't want to use the word promotion like you would in an organisation, but it is, okay, we introduce consumers at that level of, can you review these materials? As they build up the knowledge and experience, they can move further along until they are a co-investigator without the expectation they've got that same level of knowledge as a researcher. And, you know, like you wouldn't put a student in, you know, immediately to apply for an MRFF grant. You know, so I think you can still look at it in that stepwise approach, even with an individual consumer, that you're investing in them. So you could look at that as an investment curve too, as you need as a researcher and as a research organisation to invest in your consumers, and that can mean training, it can mean bringing them to team events, that kind of thing. So I think probably that's a way to view it, as an investment curve as well.
Thanks so much, Natasha. Look, I realise we're a little bit over time, so quite respectful of everyone's time. Deb, would you like to maybe close the meeting?
Yes, thank you so much to the speakers today and to everyone for joining and for the discussion. I think it's been really fantastic, and I just really like to thank everyone for their time and effort that they've put in. And we, like I said, we have been recording this, so we will put it up on the AEA website and also hopefully on our website as well, and we can send details around about that. But yeah, I'd just like to say thank you so much. Yeah, we're just very, very grateful for all your time today.
Thanks.